6 slides. We'll get through this and then number 3 as well, polyposis and colorectal cancer. So what do we have with this? There's essentially 2 main flavors right here. We've heard about Crohn's disease, heard about ulcerative colitis. Those are the 2 main flavors that we'll be talking about when we talk about inflammatory bowel disease. We'll talk a little bit about microscopic colitis. Again, that's a little bit more of a zebra, if you will, but these other 2 are going to be pretty intense. I'm going to tell you right now, please spend a lot of time paying attention to the treatments for these. There are a lot of test questions that are going to involve identifying these first order, and then obviously second order with what you will be treating them with. So here's your inflammatory bowel disease. We have those 2 conditions characterized. Now these are typically chronic. They continue to happen over and over again in the GI tract. Now pay attention, right? Grab another slide just for a visual. So Crohn's disease is any segment of the GI tract, any segment, which we see as ulcerative colitis typically is going to involve the rectum and then extend proximally. So we're going to go up the descending colon, potentially traverse, and then back down. And what we're going to see with that is that it usually sticks specifically to the colon. So, pretty visual, folks. You see Crohn's disease throughout the GI tract, small intestine, large intestine. Pretty much can be anywhere from the mouth to the rectum, whereas ulcerative colitis pretty much sticks only to the colon there. And for the most part, will only be in that last third of the distal colon towards the rectum. Now, it's not just a stomach or GI thing. What can we see that with specifically? It's like it's not showing up very well, is it? Everybody has it on in front of them, right? Just realize that there's musculoskeletal. There could be skin and oral issues. There can be hepatobiliary. And then we can get ocular as well as metabolic. So what I'm saying is this is always just going to present as, oh, I'm having abdominal pain. Oh, I'm having bloody stool. There can be different types of examples that are going to come out with that. So let's look at this. So transmural inflammation. That's just a fancy word for saying that it affects all layers of the bowel wall. All layers of the bowel wall. So it may involve the entire GI tract, that is anywhere from the mouth to the anus. So you do see a lot of presentation in the terminal ileum. And where do we know the terminal ileum is at? Right near the appendix. Okay, so right lower quadrant. Right lower quadrant. Now this can present in a couple different ways. We can have ulceration. We can also have stricturing from all that inflammation, as well as fistulization and abscess formation. So, and these extraintestinal manifestations, which is from that slide, are very common. So we do see in these folks, if they are smokers, we are more likely to see a fulminant level of disease, more likely to see a fulminant level of disease. So, how is that going to look? What we're going to see on endoscopy, and endoscopy can be either we're going in through the oral route or we're going into the rectal route. Either way, we're going to see these skip lesions. So it's not going to be continuous. These are patches of inflammation separated by areas of healthy tissue. Separated by areas of healthy tissue. So very variable because it involves the entire GI tract. So we will see periods where it exacerbates, and then we have periods where it goes into remission. So in remission, the symptoms aren't nearly as severe. Usually can go away, but we have these severe exacerbations that going to be logged with fatigue, prolonged intermittent diarrhea. Now it's usually with Crohn's because it's intermittent, it's usually non-bloody. But we also can suffer from weight loss as well as fever. So chronic inflammatory disease, that's the most common presentation there. So a lot of times it's this pre-election to attack the terminal ileum, that right lower quadrant. So therefore, people are likely going to complain initially of right lower quadrant abdominal pain. So ileitis or ileocolitis. So cramping right lower quadrant pain and it can be with or without a mass. So these symptoms, as we start getting into this chronic disease, these people suffer from malaise, so they're tired, and weight loss, fatigue, and non-bloody intermittent diarrhea. Keep in mind there's all different types of levels. It can progress because of narrowing of that lumen from the inflammation, can result in obstructions. That's from recurrent stricturing that occurs in the GI tract. So a lot of these people will complain of bloating after eating, cramping, abdominal pain, and then barbarigmy. We've talked about that as loud bowel sounds, grumbling of the stomach, grumbling of the stomach. Other things, you can get penetrating disease and can progress that bad and cause a fistulization. This creates these sinus tracts. So this is one of the main complications of Crohn's disease. So incomplete form of the fistula that extends into the surrounding tissue, usually in the mesentery, but it does not connect to another epithelial surface. So it's just going to fistulize, but it's not going to have another opening. Not going to have another opening. Versus penetrating disease. So a lot of these sinus tracts will develop phlegmon. So phlegmon, that's just that early abscess formation. So inflammatory masses get walled up, but there's not an underlying bacterial infection. Not an underlying bacterial infection. Sometimes you can find some significant masses when we palpate the abdomen, but most of this, for the most part, in this realm is an indolent disease. Now, indolent just means it causes little pain. Little to no pain. Little to no pain. So, but again, if it progresses to an abscess, it can get pretty bad. We're worried about things like peritonitis. So we're dealing with guarding, rigidity, sometimes fever, abdominal pain, significant tenderness on exam. There's these sinus tracts that can go through to the serosa and give rise to additional fistulas. So again, fistula is when it's not just a sinus tract, it means it's opening up to another side, and there's going to be all different flavors of that for you. So that can occur with the bladder, that can occur with skin, typically the abdominal area, small bowel, and then for female patients, yes, it can involve vagina as well. So how do these kind of present specifically? So that enterovesical fistula, we're going to see recurrent urinary tract infections. You can see pneumochuria. Anybody know what that is? So pneumochuria, that's going to be gas or air bubbles in the urine. So it doesn't necessarily mean it's a disease process that's occurring, but it's an underlying condition, and that underlying condition is Crohn's. Crohn's. And you have your intracutaneous fistulas, so draining to the surface of the skin, that's usually going to be in the abdomen. And then you have your intracenteric and your intravaginal fistulas. So that can be gas or feces through the vagina. Obviously, that can cause some very, very significant complications. So you can also see that in the retroperitoneum. So it can lead to psoas, abscess, or ureteral obstruction with hydronephrosis. These are significant complications. Now when you get to your pants and you see something that says anything to do with perianal disease, and specifically with fistulas, we need to know that that's Crohn's. We need to make that connection. Where we're going to see anal fissures, if those anal fissures are there, they're not going to be anterior or posterior, they're going to be lateral. So if we were to look at the rectum and say it's a clock, we're going to be looking at 3 and 9, not 12 and 6. Pretty clear on that? 3 and 9, they're localized laterally. So any number of flavors along with abscess as well as fistulas, but we get concerned about those fissures. So fistulas and fissures, you should be thinking of Crohn's. Now we talked about all these different type of manifestations. So we took at these musculoskeletal, we're going to have arthralgias or arthritis. So we can get ocular with iritis or uveitis, and then we have pyoderma granulosum. So usually inflammatory skin disease with painful ulcers, and I'll show you some pictures of that so you can have a good visual. And erythema nodosum. Where does that show up? Any ideas? You remember back, you guys have derm next semester. So that's going to be on the shins. And here's some good visuals for you. It's pretty nasty. Right? Pretty nasty. So we're going to have these extra intestinal manifestations. Those are the two that we need to be worried about as far as what can show up on the skin. Obviously, huge risk for infection with that as well. Now, what do we do? How are we going to work this up? No specific lab tests to determine that. There's no specific lab that's going to give us an idea, but we do need to see how these are manifesting with a CBC concerning leukocytosis versus anemia. Getting a CMP, we need to make sure these people don't have iron deficiency anemia as well. So all that inflammation affects the albumin levels. Good idea is that there's an inflammatory process. These are inflammatory markers. We have right there, we have CRP and ESR. And then there's this fecal calprotectin. So test measures the level of protein in your stool to determine if there's inflammation that's important. Determine if there's inflammation. And then obviously, let's get a stool culture, ova, and parasites as well to make sure that we're not having something else complicated. It's basically just to rule those out. But how are we going to determine the diagnosis? Endoscopy. Endoscopy. So typically a colonoscopy, the first to evaluate the colon and terminal ileum. So should see cobblestoning in there. And then if need be, and we're concerned because we're talking about the entire GI tract versus ulcerative colitis, which would just be in the colon, we're going to evaluate for ulcerative colitis. We can get by with just the lower endoscopy versus the EGD, esophageal gastroduodenal endoscopy. Another thing is capsule endoscopy as well. They swallow a pill, it's a camera in the pill, and it takes pictures throughout there. Eventually they might need additional radiologic studies, that's CT, MR, intergraphy. So evaluation is just really the small bowel. This is really the small bowel. Now, how do we do that? Then they're going to grade this. No, I don't need you to know how to calculate anything like that. This is as simple as you pull out IndyCalc and you plug these numbers in, it's going to give you a number. So asymptomatic intermission, that's that Crohn's disease activity index. And it's going to assign a number. And you can obviously see we get above 451, we're getting into severe fulminant disease. No, I don't need you to, I'm not going to give you a CDIA number and expect you to pick which one of these. But just be aware that that rating scale is out there. And here's a breakdown of the rating scale. Again, get on IndyCalc, figure out the CDAI, you can determine what is going to be the treatment for these people, what is going to be the treatment for these people. And I don't need you to know that chart, I just need you to know that it's out there, and it's a grading scale that has been validated to assign, to determine what you're going to do for your patients as far as treatment. What are the treatment options for them? So they stratify them either as low, moderate, or high risk. And that's all based on how significant that inflammatory process has gotten, the status of that. Is it causing ulcerations? What's their C level, their C-reactive protein, that CRP level? What's the level of their fecal cal protein, which determines what in the colon? How much what? Protein. And then it gives us an idea of how bad the inflammation is. And then upper gastrointestinal involvement. It's more likely that it's going up to the upper GI, and that can be all the way to the mouth. We need to be more concerned. It's going to increase the level of what risk that is. Here's your treatment. So you do get worried that if it's an abscess, obstruction, fistulization, it likely requires surgical treatment. At least consulting them and seeing treatment options. That all determines, ultimately, we want to improve these symptoms and control them. That results in an improvement in quality of life. So stops the reduction for that and reduction in complications as well. So is there any cure for this? No, there's no cure. Once people have this, they're stuck with it. It's just a matter of how much we can treat the exacerbations and put them back into remission. And that's how we do that. So our goal of that is to get remission with that and to prevent any recurrence or complications with progression. Again, this is an autoimmune disease. We don't all have that kind of figured out. We don't know, it can be very variable, but here's the different types of therapies for that. We have symptomatic medications for active disease and medications for maintenance therapy. So 3 different levels of that based upon their symptoms. So obviously if they're having diarrhea, what works for diarrhea? low pyramid. Or we can reach for bile acid sequestrants if there's a significant amount of involvement, specifically at the terminal ileum. And then we can give steroid preparations. So a lot of times this is intralesional injection if they have significant ulcers in their mouth. So the significant ulcers, if they have one of those ulcers before, they're pretty painful. Pretty painful, but a lot of improvement with these by treating them with an ora-base that's Kenalog, that is a steroid. That's a steroid. That's how we handle a lot of these autoimmune diseases. So if they're in this low risk, meaning no symptoms or mild symptoms, we see a little elevation in their CRP, see a little bit in their fecal calprotectin. So usually diagnosis, usually over the age of 30. So we're going to see limited distribution on this stuff, limited distribution. So no ulceration on that colonoscopy. So no perianal complications, and no history of requiring any resection. Resection is also known as a colectomy. We go in there and remove part of that colon. If they require that, they've obviously had some severe disease. They're not going to be in the low risk, mild Crohn's disease. So, and then we aren't seeing any evidence of penetrating or stricturing disease. What are we going to do to treat that? These are things I would definitely know right here. I need to know what, especially my first line. Probably going to ask you a question. It's going to be on the pants. It's probably going to be, what is my first line treatment for that? And right there, we are going to reach for budesonide. So 50 to 70%, and then we can potentially reach for prednisone or prednisolone. So people that don't respond to that, this is going to be our secondary medication. But realize that's more systemic effects. We don't like putting people on steroids for long periods of time. It weakens things. What else does steroids do to the body? Besides weakening structures. Also causes white count to go up. It's very natural for somebody who's been on steroids for a long time to have an elevated white count. Does that mean they have infection? No, that's just the body's response. So, and then you have your aminosalicylates as well. Those are alternative agents. There's the two names for you, the sulfasalazine and mesalamine. So limited clinical data. This is more of an ulcerative colitis type of thing. But just be aware that it's out there. We need to have an idea of that. Now let's say if it's diffuse colitis right there, then we need to reach for prednisolone or sulfasalazine as an alternate agent. So unfortunately, it's less effective in remission. So we see that. I want you to pay attention to these. Is where's the location of these? So we have terminal ileum, ascending colon, reaching for those, versus diffuse colitis, more left side involvement, meaning the descending colon. We're going to reach for those other medications. I need you to be very aware that yes, it is not just mild, moderate we'll reach for, but it's also potentially the location of where we're seeing the majority of those lesions. So if we can get them to achieve remission with that, then we don't need to worry about putting them on any other medication. We do need to continue to monitor to have an idea of that inflammation with those two lab tests and an endoscopy, typically every 1 to 2 years. If they get remission with that aminosalicylate, then we can continue medication for long-term follow-up scope every 6 to 12 months. Now we have our people that are high risk. So typically those are people that we catch it when they're younger, so under the age of 30. Yep, they do typically have a very strong social history that relates to tobacco use, either actively or in the past. Again, CRP is going to be elevated, that fecal calprotectin level, and we're going to see pretty significant ulcers on colonoscopy. So long segments, so a little less stiff lesionis and a little bit more large involvement. Definitely going to see some type of flavor of perianal disease as well. So whether that's fissures, fistulas, any number of those things. We're also going to see a lot of the extra-intestinal manifestations, musculoskeletal, oral, ocular, metabolic. those types of things. And then these people have typically at some point had to have a resection. So they have a pretty significant history with this. What do we reach for with this? If it's just isolated colitis, you can reach for corticosteroid or prednisone. And then these people are the ones that reach for a combination therapy. So that's called that anti-TNF, that's for anti-tumor necrosis factor. These are these biologic agents. These work very well, but just realize once they take these, what kind of class do they become? As far as, are they immunocompromised? Basically because we are immunosuppressing them. We are suppressing the antibodies, basically the immune system of the body, to keep these from becoming worse. And then they, a lot of times they add that immune modulator. So a couple different flavors of that. That's in the realm of methotrexate as well. Just be aware that when we go into this is pretty significant. You see there are a lot of people that have this issue. If you ever see any of these anti-tumor necrosis factors, there's a lot of commercials on TV today. A lot of commercials. Okay, how do we take care of that? So, remission, we make sure they're in a remission. We're going to continue them on this medication for 1 to 2 years. So the tumor necrosis factor medication. So it's pretty expensive, and then we're also running 1 to 2 years of them being immunosuppressed. So we can switch to alternate meds within the class or switch classes if their body tends to lose response to that. There's your surgical indications, so disease is not being taken care of with medications. There's potential that we need to refer them to a surgeon, definitely if they have obstruction, and then if there's any abscess formation or fistulas, that's typically something that's not going to go away, that has to be taken care of. Here's your criteria to admit people. So they're obstructed in the intestine, they have any type of abscess, and they'll get worried about serious complications. So again, these people are immunocompromised because they're immunosuppressed in some of these medications. We need to be very careful that they don't develop some other type of significant medical disease process. So get concerned if these people have significant diarrhea, dehydration, weight loss, abdominal pain, all side effects to the Crohn's disease. So, and then again, if they persist and we're loading them on steroids, we can't have somebody on steroids for lots of time. Keep in mind it's going to be multifactorial. If you're taking care of this type of person with this affliction and they're in the hospital, there's potential that you need to involve other types of people. So GI, of course, gastroenterology. So potential that you need to get a nutritionist involved because they're not absorbing everything because of the disease process. And then potentially help them out, support networks with the Crohn or Colitis Foundation of America, and then reaching for surgery if needed. Questions on Crohn's? Everybody's tracking, it can be anywhere in the GI tract. Mount Angus. Skip lesions is what we're seeing. And all be localized, whereas we're going to get into ulcerative colitis, a little bit different. So I showed you that clip right off the bat, at least separating from inflammatory bowel disease and irritable bowel syndrome. Now we're in the realm of ulcerative colitis. So idiopathic, we don't know why, we just know it's autoimmune. So this is limited to the mucosal layer of the colon. So have about 25% in the rectosigmoid colon, so that's going to be down near the rectum, descending colon. So half extends to the splenic flexure. So where's that up at? Left upper quadrant, and then another quarter extends more proximally than that. How does that look for you guys? Pretty bad if they're having pancolitis. So pan meaning everywhere in the colon. So again, this just limits to the colon for ulcerative colitis. Very similar to its friend Crohn's, exacerbations and periods of remission. Now, if it does go from mild colitis to a fulminant colitis, we're going to be very significant. Something that we talked about the last class was toxic megacolon. So now, extraintestinal manifestations similar to Crohn's disease. So you're going to see less with ulcerative colitis having fissures, or sorry, fistulas. So fissures going to be much more common with Crohn's, less common in ulcerative colitis. Now here's a fun fact, this is crazy, I don't think that they'll ask you this on the pants, but it's really wonky, is that if these people quit smoking, that it actually causes condition to worsen, which is completely the opposite of Crohn's. But these people stop smoking, actually can worsen their condition. But these people that smoke a little bit is actually protective for ulcerative colitis. I'm not telling you, you can tell somebody that has ulcerative colitis to go buy a pack of cigarettes. This is just the facts, okay?
Can we do a nicotine patch?
If they are smokers, maybe they don't have to quit right then.
Can we do a nicotine patch?
Yeah. Probably healthier, or, you know, Zen on
Yeah.
whatever. I'm not sure if they've done any studies to say that nicotine replacement is going to do that. I'm not sure exactly all the pathophysiology of it, but I don't recommend that somebody starts smoking because they have UC. That'd be weird. Well, cigarettes are so expensive anyway. So this is continuous. It's not like the skip lesions that we see with Crohn's. So universal involvement, typically rectum and sigmoid colon. Typically rectum and sigmoid colon. Continuous erythema, not the skip lesions. Not the skip lesions. And typically with Crohn's, we're not going to have a whole bunch of bloody diarrhea, but with ulcerative colitis we do. Ulcerative colitis we do. Because we're talking about the skip lesions with Crohn's, we're going to have parts that have healthy tissue. Not the same thing here. Bloody diarrhea, number one right there. And with bloody diarrhea, as you can see, obviously they're going to have more increased stool frequencies to get severe. Pulse is going to be up because they're dehydrated, they're hypotense, potentially. Hematocrit's down. All that stuff makes perfect sense. All that stuff makes perfect sense, that all that would fall in line with bloody diarrhea. Here's your mild to moderate. So where do we see this? This is a left lower quadrant pain, similar to diverticulitis. So gradual onset of that diarrhea with blood and mucus. So typically urgency. Tenesmus. So what is that feeling? What is the feeling of tenesmus? You feel like you got poop, you gotta take it down, but nothing's coming out technically. That sounds horrible, so they need to pass stool, even the bowels are empty. So usually causes pretty significant straining, cramping, and pain. So again, left lower quadrant, usually relieved when they do have a stool and they defecate. And then if we get severe, that can be greater than 6 bloody bowel movements a day. And if they're bleeding that much, they're going to be hypotense, hypovolemic, anemic. We talk about that significant inflammation is what causes that albumin to go down. So left lower quadrant pain and tenderness to palpation on exam. What do we work these people up for? We need to see how bad that anemia is. We're going to get a CMP, we see if there's any inter-organ damage. We need to get a serum albumin. We've got our similar inflammation markers along with that fecal calprotectin, stool, culture, and OMP. And here's a weird one, they also recommend getting testing for STIs for whatever reason. Make sure that that's not something that's making this worse, something else that we need to treat. Again, diagnostic is going to be endoscopy as well. In the acute period, because we know it's typically in the sigmoid of the rectal area, we can do that with a flexible sigmoidoscopy. Avoid full colonoscopy, they say right off the bat, because these people can have perforation risk. So toxic megacolon. It's not typically you're going to making the diagnosis on this, but or take the treatment on this. We just need to be aware of that. So they need to check to make sure if there's improvement after medications have been started, and then biopsy. They go and they biopsy that. We're going to see ulcerative colitis. We typically see these crypt abscesses, crypt branching, shortening and disarray, crypt atrophy. All that's just indicative of that image right there. Those are typically the things that we're going to see in ulcerative colitis. Again, similar treatment. We need to treat the acute active disease, get it back into remission, Preventing recurrence is going to be a focus for that. Preventing recurrence. So we're going to be reaching for that aminosalicylate acid, typically more with ulcerative colitis than it being an alternative when we're treating Crohn's. This is a pretty sweet slide. This is just what's called clinical practice guidance. This is put out to say, hey, here's how we want you to look at these. Here's what we want you to do from the American College of Gastroenterology. We want you to stage it, and the way that you stage it is going to determine exactly which medications that we reach for. Are we reaching for those aminosalicylates right off the bat, or are we reaching for the biologics? The biologics in the realm of the tumor necrosis factor medications. Right here, I said, I need you to know drugs of choice. Drugs of choice. So, mild to moderate distal colitis related to ulcerative colitis, drug of choice. Drug of choice is going to be that topical mesalamine. Topical mesalamine. There's a common trade names for you. No, I'm not going to mess with you and put a trade name in there. Just be aware that I refer to these a lot different. What a trade name means to me, what does it mean to me? You're going to pay more money for it. That's what it means. Okay. Now we have moderate distal colitis. So other treatments for that, topical corticosteroids right at the back. They do that in two different forms. Either way, hydrocortisone is a steroid. They do it suppository versus enema. Suppository versus enema. And maybe they've tried those, and the patient can tell you, I prefer this one works better, however. And then that oral aminosalicylate acid as well. So patients that don't want topical therapy, there's those names right there, the mesalamine or the sulfasalazine. Need you to know what is the first drugs of choice for all of these. So refractory distal colitis, so that can be with oral and topical, that aminosalicylate. They're going to add a glucocorticoid to help out with that, the topical mesalamine. Or they can add oral prednisone as well, So extensive, extending proximal to the sigmoid. So again, those aminosalicylates, so mesalamine. So sulfasalazine potential if money is an issue. So, but if we're going to give that sulfasalazine, we need to supplement with folic acid. So, and then potential for topical corticosteroids, if no improvement within the first 2 to 4 weeks. So, if that works, that topical mesalamine works, we continue to do it nightly, therapy nightly. So, if they fail, if they require the oral ASA, we just continue that therapy as well. So moderate to extensive, ulcerative colitis, other things we can reach for. Now we're going to use stepwise progression for this. So oral corticosteroids, and we can start reaching for the immune modulators and then the anti-tumor necrosis factors. Again, when we get into that, we get into more immunosuppression. We're going to be dealing with our patients that become immunocompromised. And there's some other biologic agents. So these are kind of last-ditch efforts. We failed all these stepwise progression as we go. Whenever I list all the other medications, the most popular, the drugs of choice are going to be at the top, and then stepwise progression as we get to the bottom. If we get to severe fulminant disease in the realm where it's similar to toxic megacolon, then we are in a pancolitis fulminant disease category. That person needs to be coming. They put NPO surgical consultation. They're probably going to have to get some part of their large intestines removed. Okay? You're going to have to get that surgically removed. There's this risk of abscess, perforation, those types of things. That fulminant disease can quickly progress to sepsis. Surgical indications, absolute, severe hemorrhage. Significant hemorrhage. We can only keep giving blood product, but ultimately that's going to need to be stopped some way. Perforates, and it can obviously progresses to carcinoma. And then there's your relative contraindications. I don't get too fired up about those, but I would know what my absolute are. And who we're going to consult, we need to be talking to GI, and then surgery. low threshold to admit any of these people, especially if they are on one of those biologics or the tumor necrosis factor medications because they are immunocompromised, immunosuppressed. Low threshold to send them to an emergency department to get checked out because it can progress to fulminant disease very quickly. So frequent bloody stools, anemia, weight loss, fever, those are all ideas we need to bring that person in. They're going to present with significant abdominal pain, distension, high fevers, tachycardia. That is a sepsis picture that comes into the hospital. Everybody clear on the differences between Crohn's disease and ulcerative colitis? I understand the medications for the most part. Start to cross a little bit. I'll make sure you spend a little extra time looking over that. So we'll talk a little bit about microscopic colitis, and then we'll take a quick break. I know we're getting closer to time, but again, this is a chronic inflammatory disease. So chronic watery diarrhea. This is not something you need to get all fired up about like Crohn's and ulcerative colitis. So when they do a colonoscopy, endoscopy, it's going to be normal appearing. So no skip lesions. We're not going to see all this inflammation, strictures, abscess that occurs with that. So, but they are going to biopsy that to make sure that it's nothing you need to be concerned about. This is demographic you're looking for, women, typically from age 60 to 70. Common things being common. So a lot of medications that have been tied in with that. A lot of medications, obviously anti-inflammatories, but we're looking at, we got some medications that help treat depression with sertraline, Protacine. So lansoprazole, what does that usually treat? Any idea? It's irritable bowel syndrome. So, and then we talk about lisinopril, hypertension medication, simvastatin to treat hyperlipidemia. So just be aware, this is chronic, non-bloody diarrhea, very watery. Look at that, 4 to 9 bowel movements a day, diarrhea. That's a long time to spend in the bathroom. So, but we're not going to see blood with that. They can have abdominal pain. They can also have fatigue, dehydration, weight loss. But again, that colonoscopy is going to be key. Do we want to go ahead and maybe cast a big net and just make sure it's not something else that we're missing? So you can get some lab testing to rule out different things, make sure it's not. But ultimately, that colonoscopy needs to happen. They're going to biopsy it just to make sure. Hopefully, we want to figure out and stop that offending medication. Put them on antidiarrheals, which is pretty much loperamide. And potentially, if that diarrhea goes, we do reach for steroids. And they're going to be a steroid for 4 weeks, or 4 weeks. Okay. Now, the American College of Gastroenterology puts out these recommendations. So they're going to say within 8 to 10 years after they've been diagnosed with that, they want to make sure that there's no cancer going on. So they want to go in, take a look around there, make sure there's no lesions, nothing significant. So, and then 1 to 5 years based on risk factors for colorectal cancer. We need to move that timeline up earlier if that's the case. Check on learning, and then we'll do something confused with IBS. Questions? Figure out little mnemonics in your head so you don't mix these up. A lot of these look similar in multiple slides. But we're reaching for low-risk patient with mild. And if we think back to Crohn's disease, what was the first thing we were going to reach for? B, budesonide. So if it's more diffuse, then we're going to look at prednisone. But this is mild disease. B is your answer. The key to this is that you identify that it has continuous mucosal inflammation extending directly to the spine tush. Not the entire GI tract. The entire GI tract would be Crohn's, right? There's irritable bowel syndrome, colitis. We talked about that at the end. But that would be watery diarrhea if we're going to talk about D. So everybody agrees ulcerative colitis is outstanding. Ooh. Anybody have an idea? I didn't talk about this yet. Let's see who pre-read. Nobody. So what's the answer? If they have any form of inflammatory bowel disease, 8 years. Any in 8 years, they got screened again. It's a higher risk of colorectal cancer. All right, I'll let you guys go on break, and we'll come back at 33 slides. Who do you have at next lecture? Home? But Doc Schmidt talked about amitriptyline as far as medication that can help out people that have irritable bowel syndrome. So we talked about those. So what class of medication is amitriptyline? It's a tricyclic antidepressant. Be very cautious with those. And, I'll teach you guys some toxicology stuff next semester. Well, most of you. Alright, that was so close. Hope you all do fine. Come on, check on learning. It's not going to be because of GI. Not going to be because of GI. Anyway, just be careful with those two. Tricyclic antidepressants, if that's an overdose, it's deadly. It's bad. It's really bad. My very first intubation was a 15-year-old tricyclic antidepressant overdose. There's not much you can do for it. There's not a specific antidote. Sodium bicarbonate is one of the few patients that may benefit from a gastric lavage. We go after the pills in the belly. Anyway, so just be careful with prescribing tricyclic antidepressants. Because most people that overdose on it, they're not finding it on the street or in somebody else's medicine cabinet. And it's because they prescribed it. And if they get smart, it's just a bad overdose. Anyway, I digress. Let's get into colorectal cancer here. There's some very interesting pictures in here if you've already looked at that. And I don't know what to say about this, Kelly. What the hell? I'm just guessing that that's maybe the colorectal cancer monster. I didn't want to take it out because you're like, why did you take it out? And put it in. Anyway, it's wonky. So it's like a little alien. All right, we're going to talk about polyps specifically. So intraluminal colonic tissue growth. So this is what they go in. They do colonoscopy for. They look for these. These are mostly precancerous types of things. So mostly, commonly, are sporadic. So they will go in and use like a little wire, and then they cut it and take it out and send it off to biopsy. But they're usually asymptomatic. They're just hanging out there unless they progress to cancer, but they can lead to bleeding. There's that awesome word again, tenesmus. So again, the feeling of like you have to defecate can be cramping, can be bloating, can be swelling, and that's just no fun. And then ultimately leading to obstruction that is pretty bad. If it's obstruction level, it's probably progressed to cancer. You should get a chance, at least in phase 2, or go out of your way, and your surgery rotation, you should be able to get with a surgeon, and they'll just spend the entire day doing colonoscopies and EGDs. Good chance to kind of see if they remove polyps, and occasionally somebody they can get screened for cancer, we'll go in and we'll see something that doesn't look good. And hopefully they can surgerize that before it metastasizes. Once it metastasizes, it's pretty bad. But here's how we classify these. So whether they're small, less than 5 millimeters, 6 to 9, and then large is greater than 10. So all these different morphologies. So they will describe those. Are they depressed? Are they flat? And I think they could have probably used a different word than depressed. I think it's a sad polyp. But anyway, you have your other ones, sessile, pedunculated. Here's a little picture for how those can potentially look. All different types there. So there's your flat. I'm not showing you the depressed there, but here's the difference between pedunculated and sessile. So how did that break down from there? These are the pathologic groups. So these are mucosal mostly and submucosal. The flavors there. And just have an idea that there's 4 of those. I'm not going to have which one is this. It's not going to go that way. But your most common is going to be that one, which is why these are kind of labeled 1 through 4. So dysplastic. So have malignant potential. These are the ones that they want to catch. They want to get in, they want to biopsy, check to make sure. So they can be tubular, they can be bilious, and they can be tubulobilious. So, and then there's serrated polyps as well. So that can be hyperplastic. That is not good. We do not want hyperplastic type of polyps. Those can progress as well. These are neoplastic chronic polyps, meaning they can progress to cancer. And then we have these non-neoplastic. So monotomous. So, and then they use these awesome words like polypoid, which is just a medical term describing a growth or lesion that resembles a polyp. Like, that's super intuitive, but those usually protrude from the mucous membrane or the surface. So just be aware that these other ones are benign tumor-like malformations, so a mixture of cells and tissues found in the region where they grow. So what is bad to see on a pathology report? What is bad? Something that says adenoma, these are bad words, adenomatous, dysplasia or dysplastic. That is saying that these are starting to look like cancers. It's no bueno. Versus what's not so bad, so hyperplastic or hyperplasia. Hyperplastic. Here's a nasty syndrome that we don't want anyone to really deal with, but this is familial adenomatous polyposis. So inherited disorder. Look at that, development of 100 to thousands of polyps. So developed by the age of 15, this is bad, very bad. So colon cancer is inevitable. So typically by the age of 40 to 50. And these people need to get a total colectomy. What does that mean? Bye-bye colon, all of it. All of it. It's not something I would wish on anyone, but they have to get that done before the age of 20. So, and still after they get that colectomy, they're still going to have to go and see what is left that remains in that colon, and you can make sure that nothing was left behind, meaning they're going to have to get an annual colonoscopy once a year. What's the worst part about the colonoscopy? The prep. Yeah. No fun. I had my first one last year. No bueno. No bueno. Okay, and then we have these other types of syndromes. So we talked about that word, but that HPS, and that breaks down into these Poisson-Jaggers. So oral lesions, these are not super concerning, versus a familial juvenile polyposis, increased risk of colon cancer, and then Cowden syndrome. Cowden syndrome is a rare inherited genetic disorder with multiple benign growths. So, but they have, it's kind of 50-50 with whether or not they progress to cancer. And you have to go in there and obviously biopsy those. You go in there and biopsy those. But overall, these can have increased risk. And then we have what's known as hereditary non-polyposis colon cancer, aka Lynch syndrome. These people are at increased risk of cancer. Again, autosomal dominant condition. So, and they have risk cancer in all these different spots. So, starts in the colon, obviously metastasizes and shows up in other places. So they use what's called the Bethesda criteria. So that's based on age, family history, and tumor characteristics. So did those tumors start showing up before the age of 50? Is there any family history of that with other members in the household? Again, another picture where I don't know why we have something in here from Alien. It's a great movie. Great movie, but colorectal cancer doesn't do that. Pretty sweet if it did. But here's your risk factors. Here's your risk factors. Okay? So what do we see? Most of these people are going to be over the age of 50. This is not typically a young person's issue. So personal history, obviously, of polyps. Those are pre-cancerous. The personal history of cancer, so worry about that. Is that metastasizing? So inflammatory bowel disease is another risk factor. Inflammatory bowel disease, we already talked about that. When we talk about family histories and all the inherited genetic syndromes, and then ethnicity, and then lifestyle. So being overweight, being sedentary, smoking, diabetes, high fat, low fiber diets all increase our risk for colon cancer. Again, another picture I just didn't want to take out, but I guess that's a pipe that doesn't have colon cancer. That's all I got. That's all I got. It has no obstruction. No obstruction. I don't know. I have to talk to Major Kelly and get the context on this stuff. How does this present? Typically asymptomatic. Asymptomatic, which is there's a family history. That's why we have these people we say you need to go and get screened. What do we usually do? What age do we typically screen these folks at? Unless they have like a first degree relative, we'll talk about some more. So 45 is typically when that happens nowadays. That's going to be the book answer. So some people have reported they have abdominal pain, cramping. A lot of that has to do with the change in bowel habits. And unfortunately, what do these folks do? They notice that there's a change and they ignore it. Guess what doesn't get better with age? Cancer. It doesn't just go away. And they're like, oh, let's leave this person alone. So these people have to go and get screened. But a lot of these people, when you ask them, they're like, oh yeah, I've had rectal bleeding for like the last 3 years. I've been feeling weak. I have unintentional weight loss. Those are all risk factors. Or should set your spidey senses off to something that's going on. Now, where that cancer is can result in different things. We're talking about this being in the right colon. So the right colon is in the right side of the body, as in the ascending colon. We typically see that run a little bit more with IDA, so iron deficiency anemia as well as weakness and fatigue. Left colon, because it's closer to the rectum, descending colon, we're going to see changes in bowel habits. So typically you're going to see stool streaked with blood, and most people don't look in the toilet after they're done. And that usually shows up, it's when they're wiping. And I'm like, well, you look at your toilet paper? What? It's weird. But that's just how it happens. We want to catch these things if they do that. So maybe you need to ask your patients, have you seen any blood in your stool or blood when you wipe? So see that obstructive types of symptoms. Hematochezia is just red blood at the rectum. We talk about that cool word tenesmus again. And then urgency and decrease in the caliber of stool. I've seen most doctors say, hey, you were once having something that came out that left by the diameter of a hot dog and is now coming out pencil shaped. That is concerning for colon cancer. That's concerning for colon cancer. And then how does that show up when we have metastatic disease? So complete obstruction, it's going to look like an apple core, and I'll show you what that means exactly. We're worried about unexplained weight loss, and then we ask these people about, do you have fever, chills, and night sweats? People report having that for years, and it's an underlying cancer. What do we see on physical exam? So typically unremarkable. If we take a little bit closer look, and what I do is I go back and I look at all their vitals, and I say, well, how much did they weigh a year ago? How much did they weigh 5 years ago? I'm going to look at those types of things, see if anything's going on weight loss-wise. They may not have realized it. And then a good exam, we want to make sure we're looking for any masses, and this also includes a digital rectal exam, so you can probably do a stool guaiac. So initial test, very non-specific, but we still need to get that done. Get a CBC looking for anemia, get a CMP. If there's some bleeding going on in the GI tract, then we'll probably see a what an elevation, what lab that comes out of the BNP. So BUN. BUNs go up if there's bleeding in the GI tract. Okay, that's a breakdown, the digestive breakdown of blood in there. So we want to get that. And then get an iron panel and see, are we also, maybe it's not a GI bleeding and they're just having some iron deficiency anemia. And then of course colonoscopy, study of choice, screening and diagnosis. So, and then confirm pathologically if we are dealing with malignancy. What do we see before that? Before that colonoscopy, if we get some imaging, there's your apple core. as your upper core, and that is probably just from a barium enema study. Probably never should have been done. We should have gone for the big one right here. That's that virtual colonoscopy we talked about. You can see positive arrow sign right there on both pictures, concerning for the apple core lesion, which says metastatic cancer. No bueno, no bueno. So, this can typically be slow growing, which is why we need to get these people screened. And if we do see something concerning, those polyps, they're going to make a recommendation. They remove polyps. Was there early signs of cancer in that polyp? I'm going to move up your timeline for your next colonoscopy to 5 years. I'll make a recommendation. That's not right after your colonoscopy. Come out of that, and you're like, okay, we can take some polyps out. And they'll get those tested, and they'll let you know when your next time comes like that. So, here is screening guidelines. What we're seeing here is pretty much if somebody reaches over the age of 76, we pretty much don't need to screen them anymore. So, what does that really mean? It means it doesn't benefit. And probably lived about as long as they're going to live. Doing anything invasive there is probably going to cause more damage than help. Meanwhile, we have everybody else pretty much from 40 years on up to 75. That we have grade A and B categories that we definitely want to recognize. If we can get in there and potentially remove an early growing cancer, try and treat those, okay? So screening average asymptomatic individuals anywhere from 45 to 75 years old. We do not do it 76 to 85. That's just the breakdown on that last slide. So, say no benefit after that. Consider overall health, prior screening history. I'm not saying we give up on them, but it's just not recommended. So, your average risk, okay? Colonoscopy every 10 years. So, potentially sonography every 5, and then flex sig every 5, based on where they found lesions, determines what they need to go after in the future. And you have your special based tests. There's a FIT test. That's way better than a WIAC test. And they can do that annually. And then 1 to 3 years is that FIT DNA test. So colonoscopy is still the gold standard though, because it is going to be screening and definitive. Screening and definitive. They're not usually going to do something about it. They see like it's a glaring cancer, but that surgeon can probably set them up for surgery and get, hopefully, that collected and get that removed. Here's all your stool-based testing in. So WAC, so based on your institution, they may or may not have the special chemical right there to do that in the emergency department or in your TMC. A lot of places they want that sent down to the lab now. Just realize that the fecal test right there, the detection of antibodies and hemoglobin, is much better, so more specific. And then we talked about that Cologuard. Those are people that are low risk. We do not want to. So just because they get that Cologuard, a lot of those come back positive, and then they're like, well, I thought it'd be good. Cologuard's not going to do anything. Colonoscopy is definitive. Colonoscopy is definitive. So here's what I want you to pay attention to on this. Yeah, first degree relative, 60 years, under the age of 60. Should have got screened at 45, right? Should have got screened, or we have 2 first degree relatives. We need to move up the timeline on these folks. So colonoscopy age 40 or 10 years younger than the youngest age of a relative. Youngest age of a relative. Now, here's the answer to your question, and I'll bring it back up again. We'll do the check on learning. If they had a history of inflammatory bowel disease from the time they got diagnosed with that, Crohn's or ulcerative colitis, they need to be screened again in 8 years. And then probably after that, it's going to go every 1 to 2. But their initial screening after that is considered 8 years from the time that they were first diagnosed with that. So, and then we have these other diseases. I'm not too worried about that. I need you to know inflammatory bowel disease. Chances of you seeing these other 2, not super. Now, anybody know what cancer marker we're going to order? This is after we've diagnosed them. It's not a screening test. That's our cancer marker. We want to see how high that number is. So useful for prognosis. High number, bad. Low number, not so bad. Either way, it's not good, but tumor marker for recurrence. So if we go in there, we did a colectomy, now I want to do a screening, we already found the cancer, we want to see, did it metastasize, now is it showing us on us, we are going to order a CEA. CEA. And then it's going to be a combination of surgery and oncology, because they can do that surgical resection, but they remove part of that colectomy. But what if it metastasized? Now we've got to look at other potential options. Do they need chemo? What type of screening do they need? Will there be any type of radiotherapy? So here's your prognosis. They're going to stage that for you. They're going to stage that for you. So, and if the stage increase, that's not good. So, not good. Higher the stage, rectal cancers have the worst prognosis. Worst prognosis. Everybody good on colorectal cancer? All right, go back to this again. What did I say? Ulcerative colitis, inflammatory bowel disease. At age 30, how many years for the initial? 8. 38, good. Oh boy. Remember, it's not a screening test. I only showed one of those. Don't something in the head. Somebody will do it. I don't know why. I didn't even talk about that. Did you pick the right answer? It's not a right answer. CEA, right? I don't care how many 100% happens. So first degree relative at the age of 49. What should we do? He's 10 years younger, first degree relative. That's D. He's called last name. Pronto. Pronto. Are we good? All right. This is where I leave you. You get I don't know if she can show up early or whatever. I'll be up here for a few minutes.